My name's Abe Alexander. I'm a radiation oncologist. I've met many of you before. I work at BC Cancer across the street, and I'm a radiation oncologist who treats mostly prostate cancer these days. I made a little bit of a change in my topic, so I decided to go with a little bit of a different topic. I'm going to still covering the same material, but the title of my talk is choice overload, and the reason I decided to choose that topic is because I've come to realize over the years treating prostate cancer that nowadays in 2025, there's so many choices for prostate cancer that in itself is starting to pose a problem for a lot of men looking for treatment and trying to choose a treatment. When I started, when I was training, when I was in medical school and early residency, really there were only two options. You could either have surgery or you could have external beam radiation treatment were the only two options. And so it was really easy for men to make their choice on what they wanted to do. Over the years, so many more treatments have popped up: brachytherapy, robotic surgery, focused ultrasound, cryotherapy, and there's more and more every year pop up. And as these new and more options build up, it's become harder and harder for men to choose between them. And so I was hoping with this talk to try and kind of sort through some of these many choices and see if I can kind of clear some of this up in some ways. So basically what overchoice is the phenomenon. It's also kind of choice overload or overchoice. It's a phenomenon where if we have a larger number of options, that's actually detrimental to the decision-making process. It's a lot easier to choose between two options than it is to choose between 10 options. And this is something I see every day in clinic these days, to the point where, I find some men become almost paralyzed with the number of options and really can't come to a decision just because there's so many options, and they talk to themselves around in circles trying to find the best option. When, I was hoping to demonstrate to you today that there really isn't a best option. But this slide basically outlines what I'm talking about. These are the plethora of options that we have for prostate cancer, and there's even more than this. Men today who are diagnosed with prostate cancer can choose to watch things, active surveillance, there's surgery. Even within surgery, you can have that open surgery, you can have robotic surgery. Brachytherapy is where we put the radioactive seeds into the gland, and nowadays there's two different types of brachytherapy. When we get into the external beam radiation treatment, where we kind of zap the prostate from the outside using a radiation machine, there's 3 or 4 different types of external beam radiation treatments. And then we get down to combination therapies nowadays. And for some types of cancer, it's not just one treatment. They might have external beam treatments and combine that with brachytherapy or with stereotactic treatment. And then we get into sort of the other categories, or the non-standard treatments that are available. The newest one sort of being called nanoknife, cryotherapy, freezing the gland, focused ultrasound, and lasers. And this is not even a comprehensive list. I mean, there's other treatments that I didn't list, including a lot of the medical treatments that we might combine with some of these. So there's a whole ton of treatments for prostate cancer out there, and that makes it really hard for people to choose how they want to proceed. So what I was hoping to talk to you guys tonight, I was hoping to clear some of that up. And to do that, I was going to go through and describe briefly all the standard options there are out there right now for prostate cancer. And then what I was hoping to do is compare how they stack up between each other in terms of disease control, and also kind of compare how they stack up compared to each other in terms of side effects, or what we call toxicity in the long run. It's a bit of a different way of giving a talk than I had before, and it's going to be a lot of sort of jumping around a bit and comparing between things. So hopefully it'll work out and get the point across. I wanted to just start by saying that most of what I'm going to talk tonight about pertains to what I would call localized prostate cancer. And so what I mean by localized prostate cancer is that's prostate cancer that has not spread. The prostate cancer that's only in the prostate gland, hasn't spread to any lymph nodes, hasn't spread outside of the pelvis to other areas. And that's important because prostate cancer that hasn't spread is potentially curable. And potentially curable by treatments that are applied to the prostate gland itself. The other thing that's important is localized prostate cancer, fortunately, is the most common form of prostate cancer that we treat and diagnose these days. Again, going back to when I started my training, that wasn't the case. But over the years, because of things like PSA testing and screening and early detection, the majority of patients that I see in clinic today present or discover their prostate cancer when it's in a potentially curable localized state, as opposed to 30 years ago when a sizable chunk of the men that were diagnosed at the get-go with cancer that had spread and wasn't curable. So that's the first thing, is we're going to talk mostly about cancer that is localized just to the gland. The next thing is patients who have, or people that have cancer that's localized to the gland, their cancers can be at different levels of risk. And how risky the cancer is dictates how aggressive we need to be in terms of treatment. And so in broad strokes, we divide risk up, or prostate cancer risk groups up, into nice and easy: low, medium, and high risk. And in 2025, most of the people that have low risk cancers, that's the very slow growing cancers that you read about in the newspapers, those are the cancers that are usually, we recommend surveillance or kind of watching things. High risk cancers on the other side can be very aggressive, and often those cancers are treated with combinations of treatment. So not just one treatment. Often they might have, radiation treatment and medicines, hormone therapy, or surgery and radiation treatment down the line afterwards. And in the middle is what we call intermediate risk cancers. And intermediate risk cancers are the most frequently treated cancers. That's what we see most of the time in the clinic, fortunately. They are very curable, and they're the ones that are usually treated with a single type of treatment. So that's kind of mostly what I'm going to talk about today, because the low risk cancers we usually don't treat, and the high risk are a little bit complicated and not quite as straightforward. So I'm going to focus today mostly on localized cancers, and mostly what we call the intermediate risk cancers, which are very curable. So I'm going to just touch on all the different standard treatments first. And so I'll start with surgery. So surgery is called a radical prostatectomy. And in this case, and what that involves is a surgical removal of the prostate gland, and also they remove what's called the seminal vesicles, which are little glands that sit on top of the prostate gland, kind of like little rabbit ears, and also the surgeon will often remove some of the lymph nodes in the pelvis, which are areas where the cancer can spread. Now, surgery can be done either open, and that's the top diagram there is the open surgery, or more recently, as you've probably seen in the newspaper and the news around Victoria, there's also the robotic option, which is fantastic. It's great that the surgeons have brought that to Victoria, and that's the less invasive option of surgery. You can see where the surgery is performed by trocars that are placed within the patient, and the surgeon now can sit at a little console away from the area and control the instruments, kind of like a video game. And so that's the more recent option. Surgery is a great treatment for prostate cancer. It is the most invasive option of the treatments we have. It does require a hospital stay, but it provides excellent, durable, long-term disease control. And this is a graph that just shows control rates of prostate cancer with surgery. And I'm going to be showing you a few different graphs like this showing control rates. And what I want to get across, first of all, is you need to realize that there's thousands of studies looking at disease control for prostate cancer with surgery and for radiation and for brachytherapy. And the only thing that's consistent between all the thousands of studies of, say, surgery, for example, the only thing that I can say is consistent is that the results of them are all different. You're not going to get the same result from any studies. They're all over the map. And for a lot of reasons, the cure rate that you report in the study depends on the group of people that you study, how risky is their cancer. It depends on how long you follow those people for, because your cure rate 2 years after a treatment is going to be much higher than your cure rate 10 years after the treatment, because every year more people recur. So what I've tried to do with all my graphs here is kind of try and find a study that illustrates disease control that's kind of a middle guy. It's not like an outlier study that shows, unrealistic 99% control isn't an outlier on the other end. It's sort of a middle guy that is a study that included a lot of patients that are realistic and had a reasonable amount of follow-up. I'm looking for studies with 10 years of follow-up. And when I do that, this is a very typical study of surgery for the intermediate, the middle risk category. That's the middle line. If we look 10 years after treatment, the recurrence rate is about 20%, which means that 10 years, 80% of men who have surgery will have disease control of their disease, and that's as measured by the PSA. And that's important. I want you to remember that number, 80%, because that's going to come up again. These are some of the side effects and risks of surgery, of prostatectomy. There's a surgical risks. Anytime somebody has a surgery, there's always risks of bad things that can happen on an operating room table. So bleeding, infection, blood clots, heart attack, strokes. Those risks are fairly low in 2025. The surgeons and the anesthetists are great at mitigating those risks, but those risks are there. Everybody who has surgery for prostate cancer has a urinary catheter, a urinary tube placed temporarily for a few weeks, at least after the surgery. The recovery time from surgery, even though the surgery is quick, the recovery time from it can be, in the order of 4 to 6 weeks before you're kind of back up to your normal activities, lifting heavy objects and things like that. And then in terms of some long-term side effects that can be troublesome for people, certainly there is a percentage of men in the long run after surgery will have some degree of urinary incontinence or leakiness. And there's a percentage of men that can have some degree of erectile dysfunction in the long run. And those can be problematic for some people. One really good thing about surgery, aside from the durable long-term disease control, is that people don't tend to have a lot of late side effects. And what I mean by that is if you're going to have a problem from surgery, it's usually something that happens in the first 6 months, first year. You don't tend to see a lot of people who've had surgery have side effects pop up 2 years after the surgery, 3 years after the surgery, or longer, which is important because that's something that you can see with the radiation treatment options. But surgery has a limited degree of sort of these late side effects that can pop up way down the line. And the other thing I think is important to just pass by is that surgery also has a very low risk of causing a second cancer. That's one important thing with radiation is radiation treatment is great for treating cancer and curing cancer. But as everybody knows, radiation can also cause cancer. And those risks are low and they take a long time to develop, but they could certainly be an issue for some people. I mean, I see enough prostate cancer patients that I'll occasionally see somebody who did get a cancer from radiation treatment. So that's something that's important to keep in mind, particularly if someone who's younger. So that's definitely an advantage to surgery. An alternative is brachytherapy. And so brachytherapy, it's one of the procedures that I do. Prostate brachytherapy is when we place radiation sources into the prostate gland. And the reason we do that is when you put radiation into the gland, it's a much more focused way of giving radiation. So you get the very high dose of radiation into the prostate gland where the problem is, and it kind of minimizes the doses of radiation to the neighboring organs, the bladder and the rectum and things like that. Nowadays, there's 2 different ways of doing brachytherapy. There's what we do here in Victoria, which we call LDR or low dose rate brachytherapy. And that's what this diagram shows. And that's where we use needles to put in all these little radioactive seeds. And those seeds stay there forever and they never come out. And they emit radiation at a very slow rate over time to kind of kill the cancer in the gland. There is another technique that's called high dose rate brachytherapy. We don't do that in Victoria. They do it in Kelowna. It's a very good option. And the difference is with high dose rate brachytherapy, the radiation doesn't stay there forever. Instead of seeds, catheters are put into the prostate gland, and radiation sources go into these catheters, sit there for a period of time, a few minutes, and then are sucked back out of the catheters. Or out of the prostate back into the machine, and so when the patient leaves, there's no radiation in the prostate gland anymore, and that has some advantages. Not the least of which is have somebody walking around outside with active radiation sources in their pelvis. That's a potential risk to other people. Regardless of which way you do the procedure, it's generally a day procedure. So an advantage is it has no hospital stay, and similar to surgery, it also has excellent durable disease control. And here is the disease control for brachytherapy. And so this is a study that was published just recently, comparing different ways of doing it. But the bottom line is, if you look here at 10 years, the probability of being free of prostate cancer is about 80%. Very similar to what we saw before with the surgery. These are the side effects and the risks of brachytherapy. It's still an invasive procedure, so it still requires going to the operating room, being put asleep for an anesthetic, but it's a much less invasive procedure. It's not an open surgery, there's just sort of needles. So the anesthetic risks are smaller because it's a short procedure. The operative risks are lower because there's no incision, it's just needles. And the other advantage of it is it has a very short recovery period. There's side effects, but most people can be back up to their normal activities pretty quickly. The rate of leakiness or urinary incontinence is very low with brachytherapy. and it also has a fairly low risk of erectile dysfunction. If someone's able to get erection going into the procedure, most men after brachytherapy are able to maintain erections. But it has a whole different set of side effects. And probably the biggest set of side effects that brachytherapy has is what I call acute urinary obstructive symptoms. And what that means is basically I jab a bunch of needles in the prostate gland, and when I do that, it swells up. And when the prostate gland swells up, it is obstructive on the passageway that you pass urine through. It kind of blocks that passageway and makes it hard for someone to pee. And that those obstructive symptoms hang around, certainly for the first 2-3 months after the procedure, quite significantly, and actually linger on for most people for longer than that till it resolves. And so the biggest side effects of the brachytherapy for the first while afterwards is men have to pass urine a lot. The stream is poor. They might be getting up at night a lot to pass urine, or passing urine a lot during the daytime, not emptying the bladder quite as well. Sort of a different kind of bladder symptoms than someone gets, say, with the surgery, where it's more of a leakiness issue. The other thing is, as I mentioned before with the surgery, unlike the surgery, radiation, there is a risk of what we call late side effects. And so those are side effects that might pop up 2 years, 3 years, 4 years down the line. They're a low risk. They're typically risks are in the order of 2-3%, but there are risks of side effects that can pop up years down the line. So somebody could have, say, brachytherapy, and everything is great for a year and a half, 2 years, and then 2.5 years down the line, they might have some side effect appear that wasn't there before, and some of those side effects might be difficult. So there is a risk of later side effects that doesn't happen with as frequently, at least with surgery. Third option is what we call external beam radiation treatment. And so this is where we use a linear accelerator. That's what that machine there is. And it is used to deliver high energy X-rays to the prostate gland from the outside. And the big advantage with the external beam radiation treatment is this is the option that's completely non-invasive. So there's no needles, no going to the operating room, no cutting, nothing like that. The big downside with regular external beam radiation treatment is that it's very inconvenient. Nowadays, it generally involves a total of 20, in Victoria at least, a total of 20 treatments, 1 treatment a day, Monday to Friday for 4 weeks. That's actually down from what it used to be. When I started here, we used to actually, it was 39 or 40 treatments over 8 weeks. But nowadays, it's still fairly inconvenient, better than it was, 20 treatments once a day, Monday to Friday. The other downside is some people say, and I'll explain this later, or some people wonder whether the disease control with external beam radiation treatment may be a little bit lower or less durable than the disease control with, say, surgery or brachytherapy. And I say may because no one really knows for sure. And this is another study that was done looking at the outcome of people who've had external beam radiation treatment, same as the previous graphs I've shown you. And again, if you look at the group of men intermediate risk at 10 years, lo and behold, we end up with the same, and for this study at least, recurrence rate of about 20%. So again, the disease control, at least in this study for external beam radiation treatment, is about 80% at 10 years. I'll talk to you a little bit later. I'll show some data that to why some people think it might be a little bit less effective, but at least in this study, it seems to be quite similar, and this is fairly recent data. The side effects of the external treatment, similar to the brachytherapy, but the radiation is not as well focused with the external beam treatment as it is with the brachytherapy, because as you can imagine, if I'm firing an X-ray beam from the outside at the prostate, a beam coming from the front has to go through the skin and the bone, and then it'll go through the bladder, hit the prostate gland, and on the way out, it'll go through the bowel, the rectum, and then the skin and the stuff on the way out. And so there's more radiation dose to the neighboring tissues with external beam radiation treatment than there is with the brachytherapy. And so the side effects are a little bit different, but similar. With the external beam radiation treatments, people get some bladder irritation, so that feeling that they got to pass urine more frequently, and a lot of the similar obstructive type symptoms I mentioned before. People also get a little bit more radiation to the bowel than with the brachytherapy, so people will find they get a bit of soft stool or diarrhea often during the treatment. And then, like I mentioned, similar to the brachytherapy, again, in the long run, there is this risk of late side effects that can pop up more than a year or 2 years down the line. And also because the external beam radiation treatment kind of spreads the radiation out a bit more throughout the pelvis, the risk of developing a second cancer from the radiation treatment is probably a little bit higher with the external treatments than it is with the brachytherapy. And then that brings us to the fourth option that I was going to talk about, and this is the newest one. This is called prostate stereotactic radiotherapy, or we call it SABR for short. And what SABR is it's kind of the newest form of the external radiation treatments I mentioned to you on the last few slides. And basically, it uses some of our fancier technology to kind of aim the beams a bit more accurately, a bit more precisely. And because it's more accurate and precise, instead of giving 20 or 30 radiation treatments that are small, we're able to get away with giving a small number of treatments, usually typical 5 treatments that are quite large. Each treatment is a much larger dose. And there's some thought that giving these small number of larger dose shots of radiation might have better cell kill against the tumor cells and might actually produce less damage to the neighboring cell tissues as well. We started doing this, and this is the newest of all the treatments. We started doing this originally with a clinical trial that we did in 2016, and now it's a standard option in Victoria or across BC. It's very, very well tolerated. The disease control appears excellent, but because this is the newest treatment, we don't have as much long-term data with it as we do with the others. You know, the other treatments I've talked about have been around for 20 years, 30 years. This option's only been around for maybe 10 years or so, and so we don't have as much long-term data as we do for the others. So there's a little bit of uncertainty with it. That being said, here's another graph of the disease control, and if you look at the kind of the blue and the green kind of represent the intermediate risk. Again, if we look at 10 years, lo and behold, once again, we see disease control in the ballpark of about 80%. So we're seeing a pattern here. The difference is in terms of having the stereotactic radiation treatment from the regular external treatment, it is a little bit invasive. If you want people who want to go undergo stereotactic treatment, before the treatment, we bring them in initially for a procedure, a little bit like a prostate biopsy. And what we do is we put 3 little gold seeds in the prostate gland, and that's a procedure done under just local freezing. It takes about 15, 20 minutes. In Victoria, we also were fortunate. We have this product called a rectal spacer, and at the time we put in those little seeds, I can also inject this little rectal spacer. And what it does is it pushes the prostate a little bit away from the bowel, the rectum there, and so by doing that, you get less radiation to the bowel, and people get less side effects. And then just like the regular external treatments, the machine kind of fires X-rays at the prostate gland, but we also use some fancy technology you can see down there where the machine actually tracks the location of those seeds that we put in as it's delivering the radiation. So if someone moves or their prostate moves, the machine detects that, can kind of compensate for it, and kind of always make sure that we're keeping the prostate exactly where it should be to get hit appropriately with the radiation. But yeah, despite all that, similar disease control to the other options. So what I've been trying to get at here is, regardless of whether you have surgery or whether you have brachytherapy, external beam radiation treatment, or stereotactic treatment, the disease control at 10 years, for at least for intermediate risk disease, is actually eerily similar at about 80% at 10 years. So not a whole lot of difference. That's disease control, and when I say disease control, that's measured by how low someone's PSA test gets and how long it stays that way. That's not really what matters to people. I mean, it does to a certain extent, but what's important to people isn't what their PSA is. What's important to most people is, what are my chances, or am I going to suffer problems from my prostate cancer, and am I going to die of my prostate cancer? Those are kind of the real important endpoints. We look at prostate PSA because it's easy for us to measure. If we look at studies that look at important things, for example, your risk of dying of prostate cancer, this graph shows a study that was done. This was done in BC, and this looked at compared men who'd had surgery, who had external beam radiation treatment, who had brachytherapy, and thousands of men. And they looked to see most of them intermediate risk, like we've been talking about, and they looked to see, what were how many of these men died of prostate cancer after treatment, and say within 10, 12 years after treatment. And if you look at the numbers, they're very similar. I think the most important thing I want you to take away from this is, if we look at it, the number of men who hadn't died of prostate cancer, 10 years after whichever treatment they chose, brachytherapy 98%, surgery 98%, external beam radiation treatment 95%. The vast majority of people who've had any of these treatments do not die of prostate cancer. The vast majority of them are either alive and well at 10 years afterwards, or some of them may have died of something else, heart attack or stroke or something. So I think that's the really good news is regardless of which option that somebody chooses, the chances of not dying of prostate cancer is very, very high. And it's very, very similar between the three options. There is that slight difference. There's a 3% difference there between the external beam radiation treatment and the other options. And that relates to what I was talking about before, why some people think maybe the external beam treatment's not quite as effective as the others. That may be true, but if it is true, it's not like it's a huge difference. We're talking about small differences at that point in time, which may or may not be real. So disease control and survival rates are relatively similar between all the different standard options. At least that's what I would say. And so if someone is trying to make sense of which option of all these to choose, I would argue that it's not so much important which option you choose in terms of disease control or survival. That's not really matters because it's going to be the same or similar between any of them. I think what really matters is what are the types of side effects that you're willing to risk? What are the types of side effects that are something you're not willing to risk? Is a bridge too far for you? What is a type of side effect that you can live with if it were to happen to you? And a few other things, convenience, how does the treatment fit into my life, these sorts of things. So that's what I would think is probably more important than worrying as much about the disease control. So I was going to go through this is where I'm going to jump around a little bit. I was going to go through some of the studies that have actually compared these different options in terms of their side effects. And so, first of all, this is a study that I'm going to talk about that was published recently that compared robotic surgery versus the radiation treatment, the stereotactic treatment I mentioned. And so this was a study that was, I don't know how they did it. They did it in Britain. They took a bunch of people, I think 150 people, and they got them to agree to flip a coin. And if they got heads, they got robotic surgery. And if they got tails, they got stereotactic radiation treatment. I don't know who would let themselves be randomized for that, but they did it. And their specific goal was to look at quality of life between the two treatments. And I won't go through all the details, but when they looked at the side effects, as judged by the doctor, not the patient, they found that there was really no difference at 2 years after the treatment, no difference between side effects with the bladder between the two treatments, no difference in side effects with the bowels. But when they asked the patient, things were a little bit different. When they asked the patients what kind of side effects they're having, there were some differences. And the first difference they found was with leakiness. Compared to the Sabre, the surgery had a much higher degree of urinary incontinence, with about 47% of men 2 years after the surgery having to use a pad, at least one pad per day because of incontinence, whereas with the Sabre, it was much lower, only about 4.5%. So a big difference in the degree of incontinence between the two. That being said, most of the incontinence that they found, most of the men that did have some leakiness after surgery, it was pretty mild. 88% of the men who had some leakiness after surgery, they were only using one pad per day. So very mild leakiness for most of them. So lots of people with leakiness with surgery, but most of those that do have it, not very much leakiness. And Sabre, not very much leakiness at all. That being said, when they looked at the bowel side effects in the long run, there was a little bit of a benefit for the surgery. The people who had the radiation treatment tended to have a little bit more of bowel problems in the long run compared to with the surgery. Not a huge difference, but there was a bit of a difference. But again, the Sabre people that did have some bowel issues in the long run, the majority of it were pretty mild. Only about 2% of them had bowel problems that were actually moderate. And then the last thing they looked at was erections, the sex life. When they looked at the quality of life between the two in terms of the sex life, that definitely favored the Sabre compared to the surgery. So a higher percentage of men reported a better quality of life with respect to sexual activity after Sabre compared to surgery. So their conclusions, at the end of the day, Sabre has a significantly lower incidence of leakiness or incontinence in surgery, but most incontinence was mild. Surgery has less bowel bother or bowel symptoms in the long term compared to Sabre, but most bowel bother was mild. And Sabre has better sexual quality of life than surgery. The head-to-head comparison of their disease controls is pending. So at the end of the day, again, like I said before, I think it comes down to what's important to you. If you're the type of person that's really, really afraid of the possibility of having to deal with incontinence and leakiness and having to potentially wear a pad, then surgery is probably not the right treatment for you. If you're someone that's really worried about bowel issues, then maybe Sabre is not the right issue for you or right treatment for you. If sexual function is really important to you, then Sabre is probably something you might want to consider over surgery. It depends a lot on kind of what your own values are and what's important to you. I wanted to compare the regular external beam radiation treatments compared to the Sabre option, this next one. And these two have been compared to head, and we know that they're the same in terms of disease control, very, very high rates of disease control. The big study that looked at these found that there was no difference between external treatments and Sabre in terms of side effects. We did the study here in Victoria comparing the two, and basically what we found was looking at all side effects, very few people had severe side effects. 95% or more people did not have any kind of severe side effects from either of them. When we look at sort of milder side effects and side effects between the bladder and the bowels, they were similar between the two. The green line is actually for Sabre, and it's the number of people who don't have side effects. So it wasn't statistically significant, but the Sabre may have had a little bit less side effects than the regular external treatment. I looked at quality of life. There was some suggestion that Sabre may have had a little bit less issues with urinary incontinence early on and may have had a little bit less bowel issues later on. But basically, at the end of the day, both are very well tolerated. Both had very, low incidence of side effects, but maybe a little bit less leakiness and a little bit less bowel issues with the Sabre compared to the external treatments in the long run. And then brachytherapy and Sabre, how do they compare? And so again, this is just looking at disease control is the same between the two. Red is the brachytherapy, the blue is the Sabre. And as you kind of look at it, kind of what I explained with the brachytherapy, it's not just the radiation. There's a jab all those needles in the gland that swells up, but it takes a few months for that to settle down. So you can kind of see with the red line, they have their treatment and their bladder side effects skyrocket immediately. And then it takes a few months before it actually settles down because it takes a while for that swelling to settle down. And then eventually, though, it does come down. Whereas with the Sabre, it doesn't quite, there's no swelling, there's no needles, right? So it doesn't swell up as much. So the side effects don't kind of skyrocket to the high and they tend to resolve a bit quicker. But when you look at the long run, they basically come down to similar levels between the two. So it's probably a little harder on the bladder initially for the brachytherapy. Similar pattern with the bowels. The difference being that for both the bladder and the bowels get worse initially and then stabilize. Although there is some suggestion that the brachytherapy, the bowels might get closer to the way they were before treatment, a little bit better than with the Sabre. So again, when we compare these two, both are very well tolerated, but there might be some worse bladder effects, at least initially for the first year with the brachytherapy. There might be a little bit worse bowel effects with the Sabre, but again, both very similar. I would argue in Victoria, because we use that spacer gel stuff to protect the bowel and the rectum, we probably don't see the same degree of bowel side effects they do in a lot of these studies in other places that don't use that gel. Our folks don't tend to have much in the way of bowel issues. And then one of the last ones I want to look at is how about robotic surgery and open surgery? How do they compare? Because we've been hearing a lot about robotic surgery in the papers and the news, particularly locally, because our urologist did such a fantastic job of obtaining that option here on the island. And I think it's fantastic for people on the island, not just for prostate cancer. It's going to be applicable to a whole bunch of other types of things. You know, the gynecologic cancer surgeons are going to be able to use it for their patients. And so it's really fantastic. But how do the two compare? And I just found that there is a study that was done recently. Again, one of these studies where they were able to randomize people, flip a coin. If you got heads, you got the open surgery. If you got tails, you got the laparoscopic or robotic surgery. And, you know, again, I don't want to go through all the details, but at the end of the day, what they found comparing the two was the robotic surgery had less bleeding than the open surgery, which is a big benefit because less bleeding, less chance of complications. That's good. Shorter hospitalization, again, a good thing. You know, if you're hospitalized for a short period of time, you're obviously recovering faster. Also, the longer you're in hospital, the higher the chance of you catching something in hospital. It's not a place that you want to be for very long if you can avoid it. So definitely another big benefit of the surgery. When they looked at like the complication rates, say 90 days down the line, wasn't a whole lot different. They did find that the robotic surgery may have had a little bit less incontinence, at least in that sort of initial period till about a year and a half afterwards, which is good. and there may have been a bit of better preservation of erectile function, at least early on in the first year, which again, was good. When they looked overall, say 3 years down the line, by the time you get to 3 years, the overall quality of life didn't seem to be particularly different. But again, certainly a win for the robotic surgery. If you can produce less bleeding, have a shorter hospitalization, and have less kind of side effects in that early period, that's a win for men who are having this kind of treatment. So that's I think that's really important. And then the last one I wanted to talk about, as I mentioned, there was two types of brachytherapy, the low dose rate and the high dose rate. So I just wanted to talk about that. So as I mentioned before, there's the two types. The low dose rate is what we do in Victoria, where we put in the permanent seeds that stay there forever and never come out. The radiation is given off very slowly, and eventually the seeds peter out. That's the picture on the top. And then there's this high dose rate procedure where the catheters are put in and the radiation goes in through the catheters, sits there for a few minutes, and then comes back out. They're both excellent options. Most places do the low dose rate. That's what we do here in Victoria. The high dose rate is done in less places, at least in BC. It's only in Kelowna. I'd like to have the other option because there's certainly some people who are better for one and some people who are better for the other. And I've been working for the last few years to try and see if we can get that here. In terms of the difference between the two, the HDR procedure, the high dose rate, the downside is you can't give all the radiation in one go. When you're giving the radiation fast like it does, you got to do multiple procedures. So most people do the HDR procedure twice. So it requires coming back, for two operative procedures, usually spaced by about a week. So that's a bit of a downside. But the upside is that because the radiation doesn't stay with you, you're not out walking around with radiation sources in your pelvis, you're not at risk to anybody. And also, there is, from kind of a doctor's point of view, we're able to get a little bit of a better radiation distribution with the HDR procedure. So there's some suggestion it may be a bit better. And when we compare the side effects, one of our oncologists in Kelowna actually compared the two. They're very similar, but with the high dose rate procedure that we don't have here in Victoria, the bladder side effects tend to resolve quicker just because the radiation is given quicker rather than slowly over a long period of time. And the bowels are kind of similar as well. So kind of the take home message there is they're both good, but the HDR procedure might be a little bit better in terms of the bladder and the kind of resolves a bit quicker with the bladder side effects. So that's pretty much all I was going to talk about. So the summary of what I was going to say, or what the whole point I was hoping to get across to you guys is all the standard treatments for prostate cancer are very effective. They're all very well tolerated, and they all have very high rates of long-term disease control that really is similar between all of them. And the long-term survival with all of them is excellent. There is no wrong decision. There is no best treatment. They're just different. And they differ in how invasive they are. They differ in how convenient they are. They differ in the specific types of side effects that you risk and kind of how frequently those side effects happen. And so at the end of the day, I would argue that people probably should worry less about how high the cure rate is with one option for the other and more worry about what kind of side effects are you willing to risk and how is that going to affect your quality of life in the long run. I think that's the best way to look at it. To summarize, surgery is very effective, but it's invasive. Incontinence and impotence can be an issue for some men. Luckily, men with surgery have few side effects that pop up down the line, the late one, and the robotic surgery might have some benefits, shorter hospital stay, less bleeding. Brachytherapy is very invasive, is very effective, but less invasive than surgery. Low rates of erectile dysfunction, but again, now they can have different kinds of problems with urinary stream. And then the external beam radiation treatment, very effective, but non-invasive, but very inconvenient because you've got to come in for a lot of treatments, and may have a bit of a higher risk of second cancers, and maybe a little bit less effective, but we're not sure. And then finally, the Sabre, again, very effective, convenient, well tolerated, easy to get through, but not a lot of long-term data. We need more of the kind of 10-year plus data on. And then last slide. Don't forget about active surveillance. I should mention that. Active surveillance is the strategy of not having upfront treatment, not having any of those options up front. It's the option of just sort of watching things and not having treatment up front, but when there's evidence that the disease is growing or progressing, then jumping in with treatment. It's a very good option for people who have sort of lower risk disease, people who are of older age, and people who have other significant health issues that might limit their longevity. It has the best side effect profile because no treatment has less side effects than any treatment. The important thing about active surveillance is picking the right patient for it. Not everyone's a good candidate for it. If your disease is more high risk, or you're younger, may not be a good option. But if the disease is lower risk, it's a good option. Also, the patient has to be reliable for follow-up. It's not doing nothing. It's watching things closely and jumping in when we have to. So if someone's not willing to participate in that follow-up, then it's not really going to work out properly. If done right, there's no detriment to overall survival compared to having your treatment up front if you watch things. But the key is at least half of the people who watch things do end up having treatment at some point. You don't necessarily get away without having treatment. For a lot of people, it's just a matter of delaying it, and then things work out. But if done right, survival can be the same for people. So it can be there is some higher risks of having cancer that have spread at some point in time. But when we look at survival, if done right, people can live just as long. So it's an option to keep in mind for people who it's appropriate for. So definitely that's something to ask your urologist or your radiation oncologist if you're seeing them with prostate cancer. Is active surveillance a reasonable option for me? Because if it is, that's always a preferable way to go. That's all I had to say. Thank you for your attention, and if you have any questions, let me know.